Hi, everybody. Thanks so much for coming along tonight, and so soon after last night as well. Really appreciate all of you for coming. So I've got Fatima here with me today, who's going to be giving the presentation on children and elderly. As ever, we'll just give it a couple of minutes for people to file through. As we have at the end of every session, we'll share a QR code at the end. If you could scan it and just give some feedback, that'd be really, really helpful. Just to go to the research that we're doing alongside this healthcare series. So that'd be really useful. Thank you. So yeah, we'll just give it a few more minutes and then we'll get started. Okay, we'll get cracking then. I'll just flag up before we start tonight, just our session next week. So next week, we're going to be looking at social factors. It's run by Emily Durling, who did the reproduction and fertility session a few weeks ago. I'm going to pop the link in the chat for that one. So this is the registration form for next week. So it'll be the normal time. It'll be Wednesday, 8 till 9. But anyway, I'll pass over to Fatima. And thanks so much.
Thank you, Alec. So my name is Dr. Fatima Eshani. I'm an FY1 doctor at the Queen Elizabeth Hospital in Gateshead. And tonight I'm going to be presenting on children and elderly for the LGBTQ healthcare series for Mind the Bleep. So the brief outline for today is we're going to be understanding some of the issues that affect LGBTQ children and elderly populations. We'll be talking about some communication skills, things that we can do to improve consultations and our interactions with these groups. We'll be talking then about healthcare considerations that we should be making. We'll talk a bit about cultural competency, things that kind of affect these groups. We'll be talking about barriers to care for these groups, and then we'll be talking a little bit about support networks, both for groups, but also support resources that we can use as healthcare professionals also. So let's start with understanding some of the issues that affect LGBTQ children and elderly populations. There are some challenges that might affect both groups, such as discrimination, such as mental health. But there can be some unique challenges as well that can affect the individual groups too. For example, children in schools, for example, might experience bullying and discrimination, which then might impact upon mental health issues. Whereas with elderly populations, they've lived quite long lives where they might have lived through, for example, the criminalization of homosexuality, and might experience things like social isolation, historical stigma, and fears of coming out later in life. So we'll have a little bit more of a think about specific issues that affect these groups. So to start with, according to the Stonewall School Report of 2017, 45% of LGBTQ pupils in the UK experience bullying in school. The report also shows that anti-LGBT bullying and language has decreased since 2012, but there's still a lot more improvement to be made. So from the school reports, some of the quotes from the children they interviewed: I felt like whatever I was doing was worthless. Even if I did well in school, it wouldn't matter because because all they would care about is me being gay. No one I've ever spoke to at school has ever knowingly met a trans person before or been taught anything about trans people and what we might need. Once in sex education, I asked about safe sex in same-sex relationships, and I was told that it was inappropriate and that it was not suitable for classroom discussion, and I was told to leave the room. So the Stonewall School Report 2017, I really recommend reading it. It has some really, really interesting statistics, and they've done a really thorough job. So we'll look at some of what they talk about. So in terms of bullying and language, nearly half of the pupils, including 64% of trans pupils, are bullied for being LGBT at school. Half of LGBT pupils, 52%, hear homophobic language frequently or often at school. More than a third hear biphobic language frequently or often. Almost half hear transphobic language frequently or often. The majority, 86%, regularly hear phrases such as "that's so gay" or "you're so gay" in school. Nearly 1 in 10 are subjected to death threats at school, and almost half of LGBT pupils who are bullied for being LGBT never actually tell anyone about the bullying. And these are all really, really sad statistics. And it goes to show that actually LGBT children can be some of the most vulnerable children within schools. So if we look a little bit about what form the bullying took place in, 42% was verbal abuse, but actually there are also other forms that it takes place in, such as just gossip, being ignored and isolated, but actually other things like intimidating looks, but also physical abuse, stealing, belongings, death threats, sexual assault, etc. So just a quote from the report. So George, who's 16 from a faith secondary school, says, "I lost confidence in the power to succeed and get the best qualifications. I left because I was scared and didn't belong in that environment." And I think reading the testimonials is really interesting because it does really highlight some of the real life consequences of these issues. School being an environment where children should be empowered to learn and be educated, and actually because of something that is happening to them because of the way that other people are treating them, they are actually losing this empowerment and this ability to get their education. And I think we can all see that services and schools should all be doing a lot better by these children. So a few more statistics. So 2 in 5 LGBT pupils are actually never taught anything about the issues at school. 1 in 5 have learnt about safe sex in relation to same-sex relationships. 3 in 4 have never learnt about bisexuality at school. 3 in 4 have never learnt about gender identity and what trans means at school. So looking a bit more at how schools respond, fewer than a third of bullied pupils say that teachers intervened when they were present during the bullying, which means that actually 2/3 and over 2/3 teachers did not intervene, which is pretty shocking. 7 in 10 report that teachers and staff only sometimes or actually never challenge homophobic, biphobic and transphobic language when they hear it. 7 in 10 report that their schools say homophobic and biphobic bullying is wrong, but only 4 in 10% report that their schools say transphobic bullying is wrong. Psalm 15. I truly believe that the lack of education on LGBT issues is not only wrong, but also dangerous, as we have to turn to the internet to educate ourselves on topics relevant to us. And I think that is where people, that is where children will go when their schools are not educating them. And while the internet can have a wealth of resources, parts of the internet are also dangerous for children to be navigating by themselves and alone. And actually, if we could get schools to educate children, that would almost be the best way forward. So looking a little bit at support, so more than half of the pupils said that there isn't an adult in school they can talk about being LGBT. Just 4% know an openly bi member of staff, and 3% know one who is openly trans. 1 in 4 know of an openly gay member of staff, and 22% know of an openly lesbian member of staff. More than 2 in 5 trans people say that staff at their school are not familiar with the term trans and what that means. 1 in 3 trans pupils are not able to be known by their preferred name at school, while 3 in 5 are not allowed to use the toilets they feel comfortable in. Brooke 12. I used to like school, but now I have no friends and I lack motivation to go. I will sometimes have panic attacks before and during school. So just quickly looking at well-being and mental health, 2 in 5 pupils have been bullied for being LGBT have skipped school because of this bullying. Half of the bullied pupils feel that homophobic, biphobic and transphobic bullying has had a negative impact on their plans for future education. More than 4 in 5 trans young people have self-harmed. And for lesbian, gay and bi young people who aren't trans, 3 in 5 have self-harmed. More than 2 in 5 trans young people have attempted to take their own life. For lesbian, gay and bi young people who aren't trans, 1 in 5 have attempted to take their own life. At home and online, just 2 in 5 LGBT young people have an adult at home they can talk to about being LGBT. Nearly all LGBT young people say the internet has helped them understand more about their sexual orientation and or gender identity. 2 in 5 LGBT young people have been the target of homophobic, biphobic and transphobic abuse online. And nearly all LGBT young people see homophobic, biphobic and transphobic content online. 2 in 3 LGBT young people think that online platforms are unlikely to do anything about tackling homophobic, biphobic and transphobic content or incidents when it's reported to them. So moving on a little bit to LGBTQ elderly populations. So growing old alone is much more difficult. So social isolation, lesbian, gay and bisexual people are more likely to be single, more likely to live alone, less likely to have children and less likely to be in regular touch with their family. So looking at some historical dates, so actually up until 1967, homosexuality was fully illegal, with the partial decriminalization after 1967 for the specific condition of men 21 and over in private. However, that didn't stop police harassment, and stigma continued for decades. And then we have in June 1981, the AIDS crisis led to thousands of deaths, mostly amongst gay and bisexual men. Government inaction and media hysteria increased discrimination, and many lost entire friend groups and partners. Actually, up until 1992, the World Health Organization categorized homosexuality as a mental disorder. And until 2003, there was a law banning schools from teaching anyone about homosexuality. And I think what this slide demonstrates is that actually a lot of the patients and people that we will interact with who are LGBTQ plus have lived through all of this. If we meet patients in their 70s who identify as LGBTQ plus, they will have lived through the criminalization of homosexuality, and will have all of this historical stigma and have all of this trauma that they maybe haven't even unpacked. Some elderly individuals struggle with revealing their identity after decades of secrecy. So just some other factors of things that might be increased with this. For example, higher alcohol use amongst LGBTQ plus elderly compared to their heterosexual counterparts. Increased drug use. 1 in 11 have used drugs in the past year versus only 1 in 50 heterosexual people. Greater mental health concerns, higher rates of depression and anxiety. For example, 49% versus 37% of heterosexual people. Gay and bisexual men, twice as likely as heterosexual men to have depression or anxiety. Lesbian and bisexual women, 40% diagnosed with depression, 33% with anxiety. Stonewall's later in life report found that actually older LGBTQ plus populations were twice as likely to rely on GP and social services than the heterosexual population. But actually it also found that 60%, 3 in 5 of this group were not actually confident that the services would meet their needs, which I think is an incredibly sad statistic, to need and rely on services that you don't even think are going to meet your needs. Okay, moving a little bit on to communication skills, and how we can interact with these marginalized groups to make sure that they're getting the most effective care. So we'll talk a little bit about active listening. We'll talk a little bit about inclusive language and the importance of building safe spaces. So active listening, some important points. So listen first and then assume nothing. Let patients share as little or as much as they feel comfortable. A good way of doing this is asking open questions, but also not having those open questions have any sort of heteronormative insinuations. For example, instead of asking, do you have a wife? Ask, do you have a partner, for example. Another good way to do active listening is to acknowledge and validate. So when someone has shared something with you, maybe say, thank you for sharing that with me, just to show them the understanding and the respect. Things like good eye contact, things like cues like nodding, just to make sure that they know that you're listening. And again, avoid unnecessary probing. Only ask about gender and sexuality if it's relevant to care. And if you're unsure about something, for example, a patient's preferred name, a patient's preferred pronouns, or how best to support them, just ask. I'm sure patients would rather just being asked that rather than making incorrect assumptions. So inclusive language. So one thing we can do is, if we're unsure of someone's pronouns, we could use gender neutral terms at first, use they instead of assuming he or she. But then if someone tells you their pronouns, just use their pronouns. And again, if you're unsure, then ask someone's pronouns and respect names and pronouns, and just ask if in doubt. Avoid outdated language. So terms like homosexual can feel clinical. Gay and lesbian might be preferred, but also be mindful about how language and terminology can affect different populations. For example, younger populations might be a lot more comfortable with words such as the phrase queer, but actually older LGBTQ plus populations might still associate sort of negative stigma with that word, and might not be comfortable with that. So actually just using terms like gay and lesbian can often be a safe way to go about it, and correct mistakes respectfully. I think this is a really important point, because actually no one's perfect 100% of the time, and actually if you do, for example, misgender someone, just apologize briefly and move on. Don't make too big of a deal about it, because then you can kind of focus too much on it and make it uncomfortable. But just apologize and then move on and just learn from the experience. Next, we'll talk about the importance of creating safe spaces. So, for example, confidentiality is key. Patients should feel safe discussing identity without fear of judgment, and also without fear of that information being repeated to others, if it's not necessarily, or it's not a point of safety. Visual cues matter, so things like NHS rainbow badges, sort of LGBT friendly posters, and inclusive forms. These kinds of things help. Acknowledgement of past experiences. Actually, some patients have had negative encounters with healthcare before. Instead of dismissing or minimizing, if we acknowledge that that's happened and kind of build and grow from that, and just make sure it's inclusive from there on out. It's key. And nonverbal reassurance. So just sort of nonverbal cues like a warm tone, eye contact, open posture, kind of nodding along as they're talking, just to show that you're listening and kind of taking in what they're saying. And actually, kind of quiet signals of inclusivity, kind of things like the rainbow lanyards, pronoun use on name badges, inclusive posters, gender neutral language on forms, confidentiality, reassurance. These quiet signals of inclusivity can really make a really big difference to patients who actually do want to tell you things, as long as they feel comfortable opening up. So actually, even though these feel like really small gestures, they can actually mean a lot to patients. So every interaction counts. A small effort to be inclusive can make a big difference. Meet patients where they are. Some patients might be extremely open, whereas others might be more reserved and more private, and we respect both. Commit to learning. So terminology and best practice can often evolve, and actually staying informed is key, but also remembering nobody's perfect, and if you make a mistake, just apologize gracefully and then reflect and move on. Inclusive care is better care. When patients feel seen and heard, health outcomes improve. So now we'll talk a little bit about healthcare considerations. So LGBTQ plus patients have specific healthcare needs that require sensitive and tailored approaches. So some of the issues that we'll talk about will be about youth and transitioning care, importance of mental health support and informed decision making, and we'll talk a little bit about elderly and aging issues as well. So we'll talk a little bit about the CAS review. I recommend listening to Alex's lecture on transgender health for a more thorough review of this, but we'll quickly touch on it as well. So a very quick summary. Why it's commissioned by NHS England to review gender identity services for young people. The outcome was raised concerns over puberty blockers. They called for a more mental health focus and recommended replacing Tavistock with regional services. And actually the impact has been increased waiting times, uncertainty and disillusionment amongst trans youth. So with puberty blockers now restricted in the UK, many trans youth are now forced to undergo puberty and experience body changes that worsen dysphoria. And this can lead to depression, anxiety, and suicidal ideation. especially when faced with social rejection, barriers to support, and delays in care. NHS gender identity clinics have wait times of several years, leaving many without timely access to support or home therapy. As a result, some may turn to online or overseas sources for treatment, and actually often without GP guidance or medical oversight, increasing their health risks. There is a rise in mental health crisis. Stonewall reports that LGBT youth are actually twice as likely to experience depression and anxiety compared to their peers. We'll talk a little bit about shifts in sexual health risks as well, from the point of view of healthcare considerations. So actually, access to PrEP has revolutionized HIV prevention, but actually young people might lack awareness or access, and actually HIV stigma prevents many people from seeking this preventative care. Another healthcare consideration to make is the rise in chemsex, which is drug-facilitated sex amongst some youth groups, and the raised concerns about STI transmission and consent issues. And actually, just remembering from a healthcare consideration point of view, the impact of patients who might be disillusioned from healthcare and services, and how that in turn puts those vulnerable groups at risk. So, sexual health and aging. Many healthcare providers assume that older people aren't sexually active, leading to missed screenings and discussions. And actually, in older adults, due to lack of sex education in their youth, there has been rising STI rates. Other healthcare considerations to make, so comorbidities, high rates of HIV, heart disease, and mental health issues due to a lifetime of stress and discrimination. And again, substance abuse can be a direct consequence. And thinking a bit about care homes, actually, a lot of LGBT elderly populations might fear going back in the closet in care homes due to heteronormative environments and potential discrimination from staff or other residents. Again, kind of this slide from earlier on, looking at kind of substance abuse and greater mental health concerns in LGBTQ populations. So with the healthcare considerations, kind of considering inequalities with the youth, we might have barriers to accessing inclusive care and the fear of discrimination. And in elderly populations, the historical trauma and actually the challenges accessing age-appropriate and inclusive services. So we'll move on to talk about cultural competency. So understanding diverse experiences helps deliver better and more inclusive care. So in this section, we'll talk a little bit about intersectionality and how multiple factors can actually shape experiences. And we'll talk a little bit about holistic care as well. So what is intersectionality? So intersectionality describes how different social categories interact and create unique experience of discrimination or privilege. It was coined by an American legal scholar and civil rights activist called Kimberly Crenshaw. And she introduced the concept of intersectionality to highlight how Black women experience discrimination in ways that cannot be fully understood by examining either race or gender issues in isolation. And we'll be having a look at how intersectionality might affect LGBTQ populations, but actually even in talking about LGBTQ children and LGBTQ adults, we're already LGBTQ elderly populations, we're already looking at the intersectionality between being LGBTQ and actually age. So young people and old elderly populations, both of whom would otherwise be vulnerable groups anyway, with that kind of being LGBTQ being another vulnerable social category, and actually having a look at the intersection between that. But there are also other social categories that can further exacerbate and impact upon these individuals. So looking at some examples of overlapping discrimination, for example, LGBT Muslims might struggle with both homophobia in their community and racism in LGBT spaces, making healthcare navigation even harder. Transgender patients with disabilities might face accessibility issues in healthcare settings, which can compound the already existing barriers to gender-affirming care. And, for example, LGBT asylum seekers might encounter xenophobia and legal barriers, homophobia, transphobia, leading to difficulties accessing healthcare and support services. Individuals with intersecting identities often fall through the cracks, leaving vulnerable individuals without the care they need. And actually, sometimes the separate identity groups can lack the resources to fully support and nurture these individuals, because they sometimes can not really understand how being in those intersections might create unique experiences for them. And actually, it's really important to look out for and support these individuals. It's essential for us to try and understand their unique needs and experiences without judgment, and try and step in and provide care that they deserve where possible. So looking again at the Stonewall lesbian, gay and bisexual people in later life report of specifically disabled lesbian, gay and bisexual people, almost 2 in 5 did not access health services compared to 28% of disabled heterosexual people. 1 in 4 did not access mental health services compared to just 6% of disabled heterosexual people. And 1 in 5 did not access social care services compared to 10% of disabled heterosexual people. So it's just looking out for those intersections and looking out for how being at an intersection might exacerbate already having things that already having difficulties accessing resources, and how that can then be exacerbated by being at an intersection. So thinking a bit about medical mistrust again, we talked a bit when we were looking at the dates of older LGBT people who will remember when homosexuality was classified as a mental disorder, or when conversion therapy was common. And actually these things might make some individuals quite mistrustful of the medical profession, and will remember the historical harm and damage. And actually some of what we need to do is kind of rebuild that trust with these populations, and make sure that they are accessing the healthcare that they need to, and that might include kind of more specific tailored discussions. That might just include extra time. It might just include kind of doing all of those communication skills that we talked about before. But active effort, I think, is important in kind of rebuilding trust. So assumptions and bias. So heteronormativity in care. Doctors might often assume patients are heterosexual and cisgender, leading to inappropriate screenings, e.g. Not offering smear tests as trans men. And pathologizing trans identities. Some providers still require unnecessary psychiatric evaluations before offering gender-affirming care. Just some other challenges to think about is with conversion therapy and like kind of the loopholes. The UK still hasn't fully banned conversion therapy, especially for transgender individuals. Gender identity conversion practices remain unaddressed, causing harm to trans people. Calls for stronger and more comprehensive laws to protect trans individuals. thinking a little bit about LGBTQ asylum seekers. LGBT refugees face invasive proof requirements to validate their identity, and actually the asylum system might often just disbelieve their LGBTQ claims, risking their safety. And just the trauma and the discrimination that they might face due to the lack of understanding and support. And ethnic and religious LGBT experiences. So the double discrimination that they might experience when they might be from ethnic and religious backgrounds, such as homophobia and transphobia in own communities, plus any racism they might face in, for example, LGBTQ plus spaces. So we'll be having a little bit of a think about barriers of these individuals accessing care. So past discrimination and systemic issues might lead to avoidance of healthcare, mistrust of healthcare services, again, based on past negative experiences and how that might lead to the fear of discrimination. But then also thinking a little bit about financial and logistical barriers, such as long NHS wait times, and also limited specialist services. So thinking a little bit about those financial and logistical issues, young people and also elderly groups might actually rely on that, might rely on others for things like transportation, for things like getting themselves to healthcare appointments, for example. And also, if you're very, very old and you're very, very young, you're probably unlikely to be having a job and having your own, you might have financial constraints. And because of that, you might face difficulties, and also due to limited access to specialist services and things like long wait times, there can just be other logistical issues as well. So fear of disclosure can be a barrier to care. So LGBT individuals might feel unsafe disclosing their sexual orientation or gender identity, especially in small communities or with unfamiliar healthcare providers. And again, this is where all of that communication skills section really comes in handy in sort of reassuring and actually letting them know that what they're telling you is confidential. And again, things like the small communities that can exacerbate the feeling, but actually just making sure that you are doing good communication and you're reassuring them. But then also remembering the kind of LGBT, elderly, and all the historical stigma. It's probably unsurprising that they feel unsafe disclosing sexual orientation and gender identity when they've had decades of historical stigma. So just making sure we put in that active effort into making sure that these patients feel safe and comfortable speaking to us and disclosing things that might affect their healthcare needs. So Anwar, who's 63 and from London, says, I don't think larger society has fully accepted gay people, and services for older people still lack infrastructures and sensitivity specific to older gay people. And so thinking a little bit about lack of inclusive services, many healthcare settings are not equipped to provide culturally competent and inclusive care for LGBT patients. And actually, elderly LGBT individuals may face a lack of understanding of their unique needs and their past trauma. And while as individuals working in healthcare, it's not easy to make big structural or systemic changes. What we can do is on kind of an individual level, making sure that we're doing good communication, and making sure that we ourselves are educating ourselves and being a safe space to individuals who want to share and who want to access support, and knowing what support options there are for these individuals as well, which we'll come on to in the last section. So talking a little bit about discrimination and stigma. So the fear of being judged or mistreated by healthcare providers, leading to avoidance of care. LGBT youth and elderly individuals may experience rejection or insensitivity from healthcare professionals. Just speaking from my experience of working in a hospital, I think it's easy for us when we're doing active learning and trying to be inclusive, but then it's hard when you're working in kind of environments where other people might not be doing as good of a job at being inclusive and kind of navigating that in a workplace. And I've been thinking a lot about how to go about that. And it can be hard when people like that might be your seniors, for example. But what I found quite helpful to do is to go and speak to those patients who you think might have not had a great experience, and actually just speak to them, kind of reassure them that you're there and that you are kind of listening and looking out for them, and kind of just apologizing on like colleagues' behalf, and actually just making sure that you are there in a position where that you're accessible to them, and for any sort of advice, but also just visibility that they do have someone looking out for them. And another thing to consider in terms of the barriers to care, in terms of the discrimination aspect. So looking a little bit about blood donation rules for MSM in the UK. So in 2017, the deferral reduced from 12 months to 3 months for MSM with no new sexual partners. And then in 2021, it was introduced that there would be individual risk assessment for all donors, not just MSM. But actually, with the current restrictions, there's a 3-month deferral for MSM with exclusions for high-risk behaviours. And actually, the ongoing debate is calling for a risk-based approach for all donors, regardless of sexual orientation, and actually not having like a category like sexual orientation being something that we are using, and actually making sure that everyone is treated individually and not because of an overarching group that they belong to. And actually things like this can also increase mistrust and can feel like barriers to care for some individuals as well. Derek, 56, East Midlands. I feel that as I get older, my self-confidence may diminish, and that may make me less confident in discussing my sexuality. And we've been talking a bit about kind of like the different barriers to care, but actually even in LGBT kind of elderly populations, but also in younger populations, maybe the most obvious kind of barrier is the fact that as patients get older, they might feel less self-confident and might have diminished voices. And actually, when we look at kind of LGBT young people, they might also kind of lack that self-confidence just because of their age and because they're talking to these grown-ups in grown-up jobs. And actually just making sure that we empower patients and make sure that we're the ones who are listening, doing the active listening, doing the communication, and kind of empowering those vulnerable patients to kind of share with us their experiences, and empowering them to have voice. So we'll talk a bit about support networks now. access to support networks improves health and outcomes and overall well-being. So we'll talk about specific LGBTQ services for patients, but we'll also talk about healthcare training to improve LGBTQ patient care. So LGBTQ healthcare training, what can we do? So there are some examples there of different training we can do, and again, there's always more we can do to improve patient care, in particular for those in marginalised communities in society. So there's some NHS equality and diversity training modules. There's Stonewall's Healthcare Champions, training to help organisations provide LGBT inclusive services. There's the Mermaids training for healthcare providers focused on supporting transgender youth. And there's the LGBT Foundation training, offering courses to improve LGBTQ care for healthcare professionals. And there's obviously this lecture series from Mind the Bleep. Support groups provide vital community and guidance, improving mental health and overall patient outcomes. So we've got listed here some support resources for LGBTQ under 18s. So I'll just go through them and let you have a read. I think the list includes things like in-person groups, but also kind of online platforms. And I think within there, for example, with the Colours Youth Network, creating space for LGBTQ young people of colour to explore and love the fullness of who they are. I think intersectionality kind of comes into it again, where actually the intersections between young people, LGBT, and also people of colour might be very unique and actually not something that the individual categories and groups might understand. So actually having these support resources be available for those intersections are really key. Here is some more. And some more. Yep. And support shapes futures. Every young person deserves to be seen, heard, and valued. And actually, when we think back to the earlier slides, when we were looking at the experience of LGBTQ children in schools, it seems like their experiences they have can kind of have very significant long-term effects. And actually, it's really important to signpost those resources to make sure that those kind of impacts on education and long-term kind of comorbidities is like minimally happening, and actually that we can actually just stop some of those is the hope. Emily, 64, Northeast, heterosexual older people can call upon family for help. My family is my friends, but they are my age, and so we will need to ask outside help for ourselves. Will my sexuality be considered and accepted? I think an important consideration in what Emily kind of talks about here is that while some of these LGBTQ elderly populations might have support that are their age, as they age, their support networks will also age. So it's really important to be able to signpost support resources for the elderly populations too. So we've got some from Age UK, we've got Mind Out, we've got Greensleeves Care, we've got Switchboard Helpline, Opening Doors London, and Consortium LGBT, just as a few resources that exist. And again, the Stonewall charity, where a lot of the information we've got for these slides have been through the reports they've done, but they do lots of other things as well. They do healthcare initiatives, they do training and resources, they do policy and advocacy, and they do support in community and help individuals, workplaces, and institutions create safer spaces. And their mission is acceptance without exception, and their mission is to build a more inclusive society. So that kind of brings us to the end of this topic. So good luck. Every patient interaction is a chance to build trust and inclusivity. Stay mindful, listen with empathy, use thoughtful and inclusive care. Small actions can create big changes. Keep advocating for every patient. We all have the power to make healthcare better for all. Healthcare is a universal right. Let's use intention and inclusive action to build bridges with marginalized groups. It starts with all of us. Thank you. Any questions?
Thanks so much, Fatima. That was, really interesting, really insightful to hear about the challenges that like children, young and elderly people face. Any questions at all, just pop them in the chat. The slides we will make them available on Medal, so all of those links to all of those wonderful resources will be available to you as well. And you've just put up there the feedback form. As I said, if you could scan that one and send some feedback over, that'd be wonderful. I'll just put the link in the chat as well. So this is the link for the feedback. If you'd rather just click on it. But yeah, any questions, do pop them in. I suppose what would be your, Fatima, what would be your kind of one pearl of wisdom, if you like, if someone sees either an elderly young person, queer person in the hospital, in the GP surgery or something, how do you say it's best to communicate your support or like acknowledgement of what they may be going through? How would you kind of approach that kind of patient?
That's a good question. So again, kind of leaning a lot on the section 2 of the communication skills, I think letting them lead, maybe asking open questions, allowing them to share what they want to and feel comfortable, but then also if things like the quiet signs of inclusivity are done, then maybe patients might feel more comfortable to share. If people feel, for example, that comfortable to share their own experiences, sometimes that can be a good way to kind of signal openness and make patients feel comfortable to share their own experiences if it feels appropriate. But I think honestly, just kind of signposting confidentiality and signposting that this is a safe environment to talk in, and just asking really open-ended questions, doing lots of good active listening, I think.
Yeah, definitely. I think those making the environment like clearly a safe space as well is so beneficial, isn't it? Like when GP surgeries have posters up or whatever, like saying that they welcome LGBT patients, or as you said, when people wear lanyards or like pin badges or something, that really goes to show that the people that the patients are interacting with are like trustworthy and safe people to talk to.
Yeah.
So if you don't have a rainbow lanyard, and do consider getting one, by the way. Okay. All right. Well, it doesn't look like there's any questions then. Hopefully everyone's had a chance to fill out the feedback. Thank you so much for coming. And we'll leave it there. Do come next week, Wednesday, 8 to 9, and we'll see you then. Thanks so much, everybody. Okay, bye now. Bye.